Hello, in this video we're going to look at the lower limb anatomy, and this is an overview, and we'll primarily look at the bones and also some common clinical pathologies. So here I'm drawing the lower limbs from the pelvis down. I am drawing the hip bone, the bony pelvis, which is made up of three parts: the ilium, ischium, and pubis. The sacrum at the back here joins with the ilium, or the pelvic bone, at the sacroiliac joint. This structure here is the iliac crest, which can be felt when you feel the sides of your hips. And this whole region of the pelvis is actually the ilium. The opening of the bony pelvis here is the pelvic brim. The pelvic brim differs to the pelvic inlet, which is situated more inferior. Now, the pubic symphysis is here, connecting the pubis area of the hip bone together. The symphysis is an important landmark. Keep note of this. Another important structure is the pubic tubercle, and we'll get back to this later. Here is the ischiopubic ramus, which is essentially the ischium part of the hip bone. An important surface landmark which can be felt at the tip of the iliac crest anteriorly is the anterior superior iliac spine, or ASIS. And somewhat below the ASIS is the anterior inferior iliac spine, or AIIS. Now, the ASIS and pubic tubercle is important because the inguinal ligament runs along here and attaches to these 2 points. The middle of the inguinal ligament is called the midpoint of the inguinal ligament, and this is an important landmark to remember. This should not be confused for the mid-inguinal point, which is an imaginary, which is a point along an imaginary line running from the pubic symphysis to the ASIS. The middle of this imaginary line is the mid-inguinal point. And this is also an important landmark, and we will discuss it later. So that was for the hip. Now for the femur. Now, the femoral head articulates with the acetabulum, which is a socket formed by the hip bone. The hip joint is a ball and socket joint. Important part of the femur to know are the greater trochanter, lesser trochanter, and at the distal part of the femur, we have the lateral and medial condyles. There is, of course, the sesamoid bone in the infamous patella. Now, the patella essentially works by protecting the knee joint, but its primary functional role is in knee extension. The patella actually increases the leverage that the tendon can exert on the femur by increasing the angle at which it acts. Then there is the tibia and the fibula, the bones of the legs. As you can see, the fibula doesn't actually articulate with the femur. It's really only the tibia. Now, the distal part of the tibia forms the medial malleolus, and the distal part of the fibula forms the lateral malleolus. Now let's go to the bones of the foot. The tarsus are a group of bones in the foot, which include the calcaneus, talus, and cuboid. Medially, there is the navicula and cuneiforms, which are made up of 3 bones: the medial, intermediate, and lateral cuneiforms. After the tarsals, there are the metatarsals. And finally, at the most distal part of the foot, the phalanges. So I hope that made all sense. Let's just go back to the hip bone again. So here again, I am drawing the left side of the hip. Here is the pubic symphysis, and here the pubic tubercle. And this is the anterior superior iliac spine, the ASIS. Remember, the inguinal ligament runs between the ASIS and the pubic tubercle. The midpoint of the inguinal ligament is an important landmark because right above it, surgeons know where the deep inguinal ring is situated. So remember, at the midpoint of the inguinal ligament, right above it, is the deep inguinal ring. And the deep inguinal ring is a site where hernias can occur, specifically indirect hernias. This is where the intestines can go through essentially the deep ring and then through the superficial ring and into the scrotum. This is one of the reasons why the midpoint of the inguinal ligament is an important landmark to identify where the deep inguinal ring is. So we are right now focusing on clinical anatomy, the surface anatomy. The other important landmark is where we draw an imaginary line between the pubic symphysis and the ASIS. The middle here is the mid-inguinal point. Now the mid-inguinal point is slightly medial to the midpoint of the inguinal ligament. The mid-inguinal point is important because below it runs the femoral artery, which can be palpated. And here is the femoral artery. Once the femoral artery is identified, you just have to move medially towards the groin and you will find the femoral vein and then the femoral canal where lymphatics run. There is an acronym NAVY to help you remember the sequence of these structures. And NAVY involves also the femoral nerve, which is the most lateral part and runs down the iliopsoas muscle. So lateral to medial, the structures can be remembered as NAVY. N for femoral nerve, A for artery, V for vein, and Y for lymph. The femoral artery is important because this can be an access for stenting of the heart and the aorta. Similarly, the femoral vein is important because it is an access for central lining. And to find all these structures, you just need to remember the mid-inguinal point, which is where the femoral artery is located, and then you can work medially. Drawing the same diagram again, I am adding the femoral head and part of the femur here. Again, here is your femoral artery, vein, and lymph, remember. There is a fascia type thing that runs over these structures, which makes actually an opening here. And this opening right below the inguinal ligament is called the saphenous opening. And as you expect, this is where the great saphenous vein goes through. Now the great saphenous vein drains into the femoral vein, which, if you remember, is medial to the femoral artery. The great saphenous vein actually originates or attaches from or comes from the medial malleolus and just comes right up and drains into the femoral vein here. Clinical anatomy. Femoral hernia is where there is weakening of the femoral canal. The femoral canal, if you remember, is where the lymphatics run. And the femoral canal is situated medial to the femoral vein. The femoral canal can allow intestines to enter the canal and go down and out through the saphenous opening, causing a femoral hernia. A femoral hernia is more common in women than men and have an increased risk of strangulation because of the rigid and narrow femoral canal. To finish this diagram off, there is a muscle here called the Psoas Major, which originates from the vertebrae, the spine, actually specifically the lumbar vertebrae. So it goes from the lumbar vertebrae and it goes down into the pelvic area and joins with another muscle called the iliacus. And these two will form partly the muscle known as iliopsoas. And if you remember, iliopsoas is the muscle where the femoral nerve runs along. And essentially, these muscles will then all join to the lesser trochanter of the femur. Why am I telling you all this? Well, the psoas muscles are important because a condition can arise called psoas abscess. So why am I talking about psoas abscess? Well, psoas abscess can present with a small lump potentially, but mainly pain around the hips, with or without fever. And The major cause of psoas abscess is tuberculosis or by enteric bacteria. So bacteria from the GIT can cause psoas abscess. An example can be if a patient has diverticulitis and it ruptures, and so creates a sort of tunnel where the bacteria can enter the abscess, the psoas muscles. So next I want to talk about the hip joint, and I want to introduce the ligaments. The hip joint is very stable. Here are the three parts of the bony pelvis: the ilium, pubis, and ischium, which I described at the beginning of the video. And this is the femur. The head of the femur is within the acetabulum. The hip joint is a ball and socket joint. There are ligaments that support the ball and socket joint, and there are three main ligaments, and are named by where they connect to and from. So the first ligament is from the femur to the ilium, and this is called the iliofemoral ligament. The next ligament is from the pubis to the femur. This is called the pubofemoral ligament. And the third ligament, which cannot be seen here, is actually at the back and is the ligament from the ischium to the femur, and this is called the ischiofemoral ligament. So again, there are three major ligaments that support the hip joint. The clinical anatomy of the hip joint will be discussed in a separate future video, hopefully. Let's look more closely at the knee joint now. So here is the right fibula, the right tibia, the tibial tuberosity, and the patella. There is a patella ligament, which is a continuation from the quadriceps tendon. The patella ligament attaches and continues with the tibial tuberosity. And as mentioned, the patella ligament is actually continuation of the quadriceps tendon, which is formed from muscles of the anterior thigh, which includes the quadriceps femoris and the vastus muscles. Now, between the femur and the tibial bones, there is a cushiony type substance called the menisci, and these are essentially cartilage. There is a medial meniscus and a lateral meniscus. And here we have the medial condyle and lateral condyle. Here is the lateral collateral ligament, and here is the medial collateral ligament. There is also another two collateral ligaments, which is under the patella, the anterior collateral ligament and the posterior collateral ligament. It is important to know these ligaments because, and the meniscus, because they can be injured during sporting activities or with certain maneuvers. It's important to note that some branches of the medial collateral ligament joins and continues with the medial meniscus. And so when the medial collateral ligaments are damaged, part of the medial meniscus can also be damaged. So now I'm just going to draw the same knee joint again. Here again is the patella ligament, and here is the quadriceps tendon, which is formed by the anterior muscle compartments of the thigh. Under the rectus femoris, there are a group of muscle, the vastus muscles, and we have the vastus lateralis, vastus intermedius, and vastus medialis, which forms the quadriceps tendon, part of it. And then this will then continue to the patella ligament that runs through and joins with the tibial tuberosity. It's important to point out that the vastus medialis is one of the strongest muscles for stabilizing the knee joint. Clinical anatomy: weakness of the vastus medialis can cause the patella to track laterally. The second clinical anatomy regarding the knee joint is a condition called Osgood Schlatter syndrome, which occurs in young children in particular. It is where there is inflammation of the tibial ligament at the tibial tuberosity. This usually is self-resolving and leads to a lump forming where the tibial tuberosity is, quite a prominent lump. Finally, let's talk about the ankle joint. Here we are looking at the posterior view of the ankle joint, so from the back. Here is the tibia, the fibula, the talus calcaneus, the medial malleolus. The ligaments visible here are the deltoid ligaments medially. A ligament that runs from the fibula and tibia is at the back here is the posterior tibiofibular ligament. There is also an anterior one, which is not visible, of course. Another ligament from the fibula to the talus is the posterior talofibular ligament. There is an anterior talofibular ligament as well, but it's not visible, of course. And here is the ligament from the calcaneus to the fibula, called the calcaneofibular ligament. As mentioned, there is also the anterior talofibular ligament, and it's very important to know this one, remember. And the reason being is when you have rolling of your ankle to the inside, so inversion, the ligament most commonly injured is the anterior talofibular ligament. And that's a good exam question. So through inversion, you can get an anterior talofibular ligament tear. The ligament, remember, is located on the lateral side. And again, this is the most common injury through foot inversion. But then you can have a traumatic inversion. And this can cause distal fibular fracture together with ligament tears, mainly involving the anterior talofibular ligament. I hope you enjoyed this video on the overview of the lower limb. Thank you for watching.